Hello, I did my project on the health belief model, and it's explaining and modifying two behaviors, smoking and smoking cessation, and obesity and weight loss. My name's Nicole. Let's get started. First off, we're going to do a pre-test. The questions are, how many constructs does the health belief model have? How long has the health belief model been around, and what is the health belief model used for? And finally, what's one example of the health belief model could be used for? Background information, it is on public health concerns of smoking and smoking cessation and obesity and weight loss. Smoking cigarettes. In the US, the number of adults that smoke cigarettes is an alarming 30.8 million, which is about 12.5%. Smoking cigarettes is the #1 preventable action against disease and disability. Smoking harms almost all the organs in the body in one way or another. 7 million deaths each year worldwide happen due to tobacco use. 480,000 in the United States alone. The concerns due to smoking are cancer of the throat, lung, base of tongue, and mouth, among other organs in the body, coronary heart disease, stroke, respiratory diseases such as COPD and chronic bronchitis, pregnancy issues, rheumatoid arthritis, and many more. Smoking cessation. Most Americans who smoke cigarettes want to quit. In 2015, 68% of smokers wanted to quit smoking. Over 50% of smokers said they have tried to quit smoking. That doesn't necessarily mean they were productive in doing so. There's a large number of reasons to quit smoking, and the main one being improved overall health. Why is this important to the field of health education and behavior? Smoking costs the U.S. large amounts of dollars ranging in the hundred billions. Less than 1 out of 10 smokers who try to quit accomplish it. Small amounts of information and advice from a healthcare provider can increase the number of people who quit smoking. Smoking cessation advice is low cost. All it costs somebody is time to give that information to someone. Marketing tobacco products is a billion-dollar industry. In 2017, the prevalence of obesity was 40%. Being obese is being a weight that is considered unhealthy. Body mass index, or BMI, is used to help to determine if someone is obese. Factors that can contribute to obesity include physical activity levels, sleep routines, eating patterns, genetics, and medications. Obesity can lead to other conditions including diabetes, cancer, heart disease, and a reduced quality of life. Weight loss. Small amounts of weight loss can make a difference and improve health. Healthy weight loss is 1 to 2 pounds a week. Diet is not the goal, but a lifestyle change. Lifestyle changes of healthy eating, physical activity levels, and stress management. Health benefits of weight loss are improved blood pressure, improved cholesterol levels, improved blood sugars, and a lower risk of cancers. Why is this important to the field of health education and behavior? Obesity is a costly chronic disease. It increases healthcare costs. The medical cost of obesity is very large. It's $179 billion stated in 2022. A healthy weight person's medical cost is approximately $1,861 less than an obese person's medical cost. That's almost $2,000 in medical costs that someone who's obese would have to pay more. Health education specialists can help to lower the prevalence of obesity by working with people to become and maintain a healthy weight. The health belief model. What is the health belief model? The health belief model is a theory that is used to help predict the likelihood that a person can adopt and stick to a health behavior. It's used to predict behavior. It was created in the 1950s to help understand why people would fail at health behaviors, prevention strategies. It was discovered when people would not get tuberculosis tests even though they were coming to people's neighborhoods. They wanted to know why people would not do it. The health belief model has 6 constructs to help explain it. It depends on people's perceptions, beliefs, and barriers, and their benefits. The constructs of the health belief model: perceived susceptibility, perceived severity, perceived benefits, barriers to actions, cues to action, and self-efficacy. This is a diagram of the 6 constructs of the health belief model. It's the ones I stated on the last slide. Perceived susceptibility, perceived severity, perceived benefits, barriers to actions, cues to action, and self-efficacy. Health belief model constructs explained. Perceived susceptibility is the belief of getting a disease or condition. What is the likelihood of you getting a disease or condition? Perceived severity is the belief of how serious it is that you may get a disease or condition, as well as leaving one untreated and its consequences. Perceived benefits. What are the advantages to doing a specific action or task? The benefits can be health-related, reduced threat, financial, or social. Perceived barriers or barriers to action are beliefs of what is stopping someone from doing an action. What obstacles are there and what are the consequences? Barriers are negative and can stop someone from doing an action. The consequences can be tangible or psychological. Cues to action can be internal or external factors that can affect a health behavior. And self-efficacy is the belief that you can accomplish an action, or otherwise your confidence in doing so. The limitations of the health belief model. It does not consider the way a person may feel about a certain health behavior. It does not consider habitual behaviors. It does not consider social acceptance as a reason for a behavior. It does not account for environmental or economical factors of an individual. It does not consider that everyone does not receive the same information. And then, quoted from Lamorte, it assumes that causes to action are widely prevalent in encouraging people to act, and that health actions are the main goal in decision-making process. But that's not always the case. Overview of studies. This overview is for smoking and smoking cessation. It's from the article Effectiveness of Health Belief Model in Motivating for Tobacco Cessation and to Improving Knowledge, Attitude, and Behavior of Tobacco Users. The experiment using the health belief model to educate by improving knowledge, attitude, and behaviors of current tobacco users towards tobacco use. The methodology is a questionnaire given, socioeconomic status assessed, intervention with 2 stages, health education model was developed, and a leaflet and health education video developed. The intervention was based on 6 health belief model constructs, and the leaflet and video were used as cues to action. Health education was delivered individually by a 16-minute video. Subjects were asked to come back for a 2-month follow-up and re-interviewed, which again assessed knowledge, attitudes, and behaviors. The data was analyzed as statistical, descriptive, stratified, and correlative analysis. The demographics was 20 to 35-year-olds. It was 88 tobacco users in the study, and they attended dental clinic visits in India. The findings were using the health belief model, patient education was effective in motivating people to quit smoking and enroll in a smoking cessation program. It also improved subjects' knowledge and attitudes towards smoking. The recommendations were to conduct a larger study for a longer time on the general population and using the health belief model to change people's knowledge and attitudes towards smoking. This is a second study for smoking and smoking cessation. It was the development and validation of the health belief model questionnaire to promote smoking cessation for nasopharyngeal cancer prevention, and it was a cross-sectional study. The study was done using the health belief model to predict intention on smoking cessation. The methodology is it's a cross-sectional study. 8 trained researchers collected the data. The health belief model method questionnaire was 34 items categorized into 2 sections, 6 constructs, and health behavioral intention. Both sections used a 5-point Likert scale, and the first section consists of 30 items in categories of the 6 health belief model constructs. Section 2 includes 4 items that predict the health, behavioral, intention. And on the side, I have a little flow chart that just shows the process of them making the questionnaire and the analysis of it. It's validating how they did the questionnaire. The demographics for this study was in Malaysia, mainly males 30 to 39 years old. Phase 1 had 100 participants and Phase 2 had 171 participants. It was people in urban and suburban areas who were smokers, at least 18 years of age, who had smoked for at least a year, and it is from this area of Malaysia. The findings for the study showed to be valid and reliable for predicting smokers' health, behavioral intention to quit smoking in order to reduce cancer. The recommendations used the health belief model to have smokers quit in order to reduce oral and other smoking-caused cancers. And this is a little chart that they used for the Likert scale and questionnaire on the concepts, or I'm sorry, the constructs to the health belief model with the susceptibility, severity, benefits, barriers, cues to action, self-efficacy, and then also they added behavioral intent. This study is also on smoking and smoking cessation. It's factors affecting cigarette smoking based on health belief model structures in pre-university students in Isfahan, Iran. The goal of the study was to define a connection between cigarette smoking and the health belief model and its 6 constructs. The methodology was a systematic randomized sampling of 8 schools. Statistical analysis used for the samples was SPSS.V.18, chi-square, and independent t-test. The demographics were males aged pre-college, basically teenagers, 382 participants in Isfahan, Iran. The findings were stated in the article as the mean age of the students was around 18 years old. Overall, 7.2% of the students reporting having smoked in the past 30 days, 32.7% of the samples reported ever having smoked in their lifetime. The results of the t-test show that there were significant differences in knowledge, perceived susceptibility, benefits, self-efficacy, and cues to action between smokers and non-smokers. And as the article states for recommendations, these results suggested that the constructs of the health belief model can be incorporated when examining the predictors of cigarette smoking and developing smoking prevention programs among pre-college students. Furthermore, with a better understanding of the factors affecting the complex behavior of cigarette smoking, it can be a useful step to reduce the rate of death, cost, and improve community health outcomes. So basically, they're recommending that by using the health belief model, there are improved situations in smoking cessation, health, and it can also limit deaths and costs. Moving on to studies of obesity and weight loss, this one is effect of lifestyle modification, education based on health belief model in overweight obese patients with non-alcoholic fatty liver disease, a parallel randomized control clinical trial. The methodology was parallel randomized controlled trial, 82 NAFLD, which is non-alcoholic fatty liver disease, patients recruited and allocated to intervention group or the control group. There was questionnaires, knowledge, blood work, sonograms, dietary intakes, and physical activity collected at the beginning and 2 months after intervention. The intervention group received intervention given once a week for 8 sessions. Intervention included lectures, slideshows, pamphlets, and discussion, and was based on the health belief model, and they were encouraged to eat a healthy diet. The control group received usual care at the fatty liver clinic. The demographics for this study were participants from a fatty liver clinic in Seraji Tahari, 82 participants in 2 groups, control and intervention using randomization. The findings were after the study started, it ended with 36 patients in intervention group and 33 in the control group, and there was improvements in knowledge and all aspects of the health belief questionnaire for the intervention group, as well as improved liver enzymes when compared to the control group. Basically, the findings were that they had improved health situations from losing weight. The health belief model recommendations were a lifestyle modification and education was effective and impacted knowledge and could be used to impact patients' minds and bodies, not only in this study, but other health-related weight loss studies. This is a second study on obesity and weight loss. It's the determinants of daily exercise among employees with overweight or obesity, the application of the health belief model. The methodology was a cross-sectional study with a self-made questionnaire based on the health belief model. It was done in 3 parts and used a Likert scale. The demographics was 101 overweight or obese healthcare employees that lacked chronic disease with a BMI over 25. The findings were the mean exercise of males was higher than females. The best predictor of daily exercise was self-efficacy, and there was a 63.37% of no daily exercise among participants. The recommendations was that the health belief model be applied to interventions and can reduce cardiovascular disease and obesity. With improved self-efficacy, people may improve daily exercise. Synthesize. I'm going to put all the pieces together. Synthesize smoking and smoking cessation. Overall, I learned that the health belief model is a great predictor of whether someone will quit smoking, that it showed that the knowledge of study participants varies greatly from person to person, and the constructs help to prove that. These studies on smoking and smoking cessation just reinforce the need for health education specialists and the need for educating people on health scenarios like smoking and quitting. The health belief model is common and proven to be effective as a health behavior predictor and will continue to do so in future smoking studies. Across the studies, the recommendations showed that the health belief model can help change people's attitudes, knowledge, and beliefs and disease outcomes. The health belief model constructs help to categorize areas to help an individual with how much they understand. Synthesize obesity and weight loss. Overall, I learned that the health belief model is a good model to judge and predict weight loss and disease reductions. The findings and recommendations showed that using the health belief model constructs for questionnaires that knowledge and self-efficacy can improve, and the questionnaire can show what you need to work on to meet goals like physical activity. The study showed with help of the health belief model, lifestyle modifications and knowledge can lead to reduction in BMI and improved health. Which behavior better fits the health belief model? I believe the better fit is for obesity and weight loss rather than smoking and smoking cessation. I think it works well for both, but with smoking, there's a lot of other issues that are not considered, like habitual behaviors, non-health reasons for an action, like social acceptance, and smoking involves other things that aren't considered. Conclusion. Smoking and smoking cessation. For both scenarios with smoking and smoking cessation, I would apply the health belief model and use questionnaires, Likert scale, and the 6 constructs. Perceived susceptibility, severity, benefits, cues to action, barriers to action, and self-efficacy. In both scenarios, smoking and obesity, I would give patients or participants information about obesity in either smoking cessation or weight loss, and smoking, and do a 3-month follow-up to see if anyone either quit smoking or loses weight. Participants are volunteers that are either smokers or have a BMI over 30. And then these are my questions that I would ask based on the 6 constructs for smoking. It would be, what are the chances I could have a negative effect from smoking for perceived susceptibility? Perceived severity is how serious are smoking-related conditions and the consequences. Pain or death is an example. Perceived benefits, what are my benefits from quitting smoking? Cost savings from cigarettes, no smoke, smell, etc. Barriers to action are what's stopping someone from quitting. Crowds, social crowd anxiety, irritability, stress management. Cues to action is what is going to make me think about or actually try to quit. Someone you know dying from something like lung cancer is an example. Self-efficacy, how confident am I that I can actually quit smoking, and are you capable of quitting? This is the same thing, but in the weight loss version, which I already went over a little bit. And then the questionnaire would be based on the 6 constructs, just like for smoking, which would be this perceived susceptibility, which is what are the chances I could have a negative effect from being obese, such as CVD, cancer, stroke. Perceived severity, how serious are obesity-related conditions and the consequences, such as pain, death, quality of life. Perceived benefits, what are my benefits from losing weight? Feel better, health conditions, risk improve or lower, save money on medical conditions, may be able to get some time, get off of using some medications. Barriers to action, what's stopping me from losing weight? Do I not have time to work out? Can I not afford healthy food? Fatigue. Cues to action, what is going on to make me think about or try to lose weight? Menus with nutritional information might be a cue to action. Family member or friend dying from a condition caused by obesity. And self-efficacy, how confident am I that I can lose weight? Do I think I will be able to stick with it? And here's the post quiz. It's the same questions as the beginning, but it might be able to be answered more efficiently now. How many constructs does the health belief model have? How long does the health belief model been around? What is the health belief model used for? And one example of the health belief model could be used for. And here are the answers. It's got 6 constructs. It's been around for 60+ years. It's used to predict behavior change. And then based on the presentation, an example is smoking cessation or weight loss. And here's a list of all my references. Thank you for coming to my presentation.